I was part of the European Society of Cardiology guideline for atrial fibrillation, and I took part of the group. I led the group of Avoid Stroke, and we discussed a lot about some issues. For example, having a stroke despite anticoagulation, and this is still an open area, because what can we do? Patient is let's say a patient is adherent to treatment, is fit, and he has another stroke. So what can we do in this kind of patient? And probably one of the questions will be answered by the Laos 4 trial, where these patients will be treated on top of anticoagulation with left appendage occlusion. So this is an unmet need. We still do not have the results of this trial, but and there's another trial, also a Swiss trial led by David Seifke. So hopefully in a short time, this answer will be this question will be answered. Second point, what we discussed is the rhythm control after in a cardioembolic stroke. We know now clearly from studies in primary prevention that rhythm control reduced the risk of stroke. But what to do in patient who had a recent stroke? Shall we start early? Shall we start in a delayed way? Because there are some sub-analysis of the EAST trial that showing that patient who had a stroke and underwent rhythm control had lower risk of having a stroke. So this is a very important question still to answer. The third point is also the reversal of a patient who had bleeding due to anticoagulation, because still we have some data on andexanet, still it has to be shown if it really works in real world, because we know from the trials that there is certainly a risk of having ischemic stroke. So I think these are the main points. And then what we did, just for my personal work, we removed the sex as an additional point, because it was not really an additional point, to select a patient or to score the risk of a patient with atrial fibrillation. There we used the CHA2DS2-VASc score in the past. Now we move to CHA2DS2-VA. It seems that it's gender unfriendly, but in reality it's not true, because myself was the one who pushed this more, and I'm always working on gender, because I want that the woman has the same probability of getting treated as a man, because women are still undertreated. And in the CHA2DS2-VA, the final score was the same for men and women, even if they had, because you needed 3, one for the sex point for women and 2 for men. So in the end, it was the same score, and it only created confusion. Having only one score for the whole population makes everything easy, and women needs to be treated as men for the prevention of stroke and atrial fibrillation.